I'm Nick Sanders, instructor for integrative dry needling. I'm here with Frank Gargano, of course, the president of integrative dry needling. And we're going to talk a little bit about dry needling and manual therapy and some different things. So we definitely want to talk about Mulligan. You got your start kind of in the Mulligan career. Yeah. Tell us about how'd you get started with Brian Mulligan and that crew?
You know, Brian Mulligan I took my first Mulligan course in 1994. And I was blown away. And the whole reason I went to the course was a buddy of mine went to the course. He did a little in-service, and he had one of his techs, and they had a bad big toe, and he did a little mobilization movement, changed it. The kid's like, I haven't been able to do that in years. I thought, I need to go to that course, right? So I went to a course with Brian, and Brian, who's brilliant, both in the concept and just how he delivers the message up there. And I was blown away by it. And just so happened that about a year or so later, he asked me, he said, I'd like you to help me assist. So that was one of those moments in your career where you remember back on that. It's a big deal when Brian Mulligan asks you that. So vis-a-vis, fast forward, I then became a full instructor, and then eventually ended up sort of being on the executive committee. And I ran all the finances for the Mulligan concept for 12 years. So I got to meet a lot of great people. It changed the way that I practice. I mean, without a doubt.
Yeah, those things that make those instant changes are just, why would you not want to know how to do that? For people that haven't seen it before, what is Mulligan?
So Brian, again, way back in the day, was a master manipulator. He taught manipulation all across the world, really. And you can see the stories, but essentially what he came up with is the idea that if it's a positional fault theory. That's what it is now, and what he had talked about. And it's really just about a little bit of a change in a joint position. And if you make a change back, that immediately takes away the pain, immediately restores the motion. So he always described it as just changing joint position. And what we do know now is it's much more than that. It's much more of a neurological concept. So now there's books out there that have been written about the Mulligan concept. I mean, back when I first took it, there were no references, there were no research articles, nothing. Today we have probably about 300 or so, and 3 or 4 books that have come out on the mobilization movement concept.
Can we dive into that neurologic piece? I find it interesting because, as you know, I do some Mulligan stuff. It's interesting how subtle changes make such a big difference with Mulligan. What do you think that's attributed to, and why is it so successful? Yeah,
and I think it goes back to the neurology for sure. They're making small little joint changes. Sometimes they're so imperceptible that I don't even think you're moving the joint. But just by making subtle little glides like that, you're going to change the input, right? Whether it be a sensory input, whether it be a capsular input. Certainly then, the brilliance of what Mulligan did was he added this mobilization, but then it's the addition of the movement, right? So once you do a movement of a joint and you incorporate the muscular aspects of it, you take the neurological input to 1,000 times that, right? And I also think, that repetitive movement that they're doing is neuromuscular retraining. And by doing that neuromuscular retraining, that's why the Mulligan concept has a lasting effect. And that's one of the prerequisites too, that if you're going to do something with the Mulligan concept, it's either going to work or it's not. Really quickly, you're going to decide that. And then you got to have that continual carryover. Yeah. And that's what I've seen over the years with Mulligan, and that's why I recommend it to pretty much all the students that I see.
Yeah, likewise. And it is always amazing to me, especially with the neck and the snags in the neck. Like, you're not pushing enough to do anything. And all of a sudden it's like, oh, I don't have any pain when you turn. And it's just one of those really cool things. And so then how did you transition from, obviously doing a lot of Mulligan, teaching with Mulligan, where did dry needling fit in? How did that all happen?
Yeah, so I was in Georgia, and I was teaching at a buddy of mine. I was doing a Mulligan course actually in Georgia with Stuart. And Stuart at lunch maybe said, hey, have you heard of this dry needling stuff? I said, no, what are you talking about? And again, this was probably back in 2007 or so. I said, no, what are you talking about? He said, well, there's this Asian guy, and he's out there teaching this thing called dry needling. You got to check it out. So I did. I checked it out, and it was Dr. Ma, my mentor in dry needling. So I called him, and I said, why don't you come out to my clinic and do a course for us? So I had my first dry needling course with Dr. Ma probably in about 2007 or so. And then, we hit it off, and I'd go out to Boulder, we'd train, we'd do research, we'd come up with courses. We did all this stuff together for many, many years. And in 2013, he asked me, he said, will you take over my concept? I want you to take the concept over. So in 2013, I developed the Integrative Dry Needling Institute, added my 2 cents to his already brilliance of the dry needling model, and added a lot of orthopedic components to it. And that's kind of what it's kind of evolved into today, is the IDN Institute.
And obviously those worlds blend very well with that neurologic approach. How do you see them intertwining between the Mulligan and dry needling?
You know, when I was sitting in that course, that very first course with Dr. Ma, and I was listening to him talk about the neurology of dry needling versus just maybe a trigger point or something else, and really looking at the systemic side of it. And it just made me think, look, this is exactly why I do Mulligan, because Mulligan is a manual therapy. It's a joint kind of based thought process, but it really is neurology. And when he started talking about dry needling and the systemic and the segmental effects, I knew that if we could combine and do a mobilization with movement, go through the repetitions, if somebody still has residual soft tissue involvement, adding the needling component to it, I mean, again, Mulligan changed the game, dry needling changed the game. Putting those two things together, it's amazing the results. And the results that you get are quicker. Right? I mean, I think you get less number of visits, and I think the results have a longer lasting effect to them.
I agree with you, and I think they intertwine. Like the play between them is really nice. Like there's times where maybe you can't quite get a Mulligan technique to work, but then you do some like sensory nerve needling, and then the Mulligan technique is that much more effective, or vice versa, right? Kind of that clearing. It just can be so powerful. So if you had to tell somebody, like you had a Mulligan instructor or a Mulligan practitioner, and you wanted to explain them, why would you do dry needling? What would the big answer to that be?
Well, I think it's, in dry needling, the benefit of dry needling is the lesion, right? I mean, in what we do now in physical therapy, there's nothing that we create from a lesion standpoint. And the power of dry needling is creating that lesion. So we're able to tap into the nervous system at a level, and the endocrine system, the immune system at a level that we could never do before, just with our hands. So adding NWMs and putting IDN into that just takes that neurology up to another level, the neurological effect up to another level. And that's really what I've done my entire practice. I've been practicing for 30 years, right? It's usually I start with an MWM, and then I'll go into more of the dry needling piece. So it's those two things together, and then functional retraining, right? The exercise piece after you've normalized joint as much as you can, normalized tone in the neurological system, adding that functional movement and that training has been really my go-to now.
Yeah, I talked to Dave about this a lot, one of our other instructors. Why joint first? Like, why do you?
I think it goes back to my training, right? I mean, I was a manual therapist way before I knew anything about dry needling, and that was always the thought process, is that you start centrally and you work your way out from there. And I still think that's the case with dry needling, because no matter where you put a needle into anybody, you have a neurological effect. And we've also shown that you have a neurological effect centrally. So whether you put the needle here, here, or here, the brain will light up when you're doing that. So that the combination of those two things, really changes the game in how somebody responds to it, and with the speed upon which they respond. Yeah,
I agree with you. That lesion is there's something different about the way the body and the nervous system, the immune system, and that interaction is definitely a different play. Why do you think I think there's still a lot of resistance towards some of the dry needling world. There's still some resistance to that. Why do you think people have objected to it, or maybe hesitant to take on that neurologic approach? Like, we're still thinking about muscles and how do we change the muscle tone and all that kind of stuff. Why do you think that hasn't happened yet?
Well, I think it has. I think it. Well, I think it. Yeah, I think it is. Yeah. But since the 1950s, even before that, I mean, we think about Janet Travell. I mean, she's really the one that brought it out, right? The myofascial trigger point model came out, and she had amazing, brilliant books, the little red books that most of the young people don't even know what I'm talking about with the Travell books. But she brought that out, and she made a great case for it, and it was brilliant, right? So we got ingrained into that myofascial. So most of the research that you'll see and that you'll read is all about myofascial trigger points. But pain science now, what's pain science doing? Pain science now is really looking at the neurological aspects of it. In our courses, we talk about quantitative sensory testing, right? That's looking at peripheral nerve irritation and trying to measure the amount of central sensitivity that somebody has working for them. So those two things together, the whole, I think, manual concept still holds tremendous value, but now we're actually moving more towards the neurological response to what manual therapy does, and certainly what dry needling does.
Yeah, there's such this hard road right now between like the pain science people and then the hands-on manual therapy people, and I don't understand why we have to be on these two separate camps, right? Like, we're all talking the same thing. We're trying to change the interaction of the brain, the way we're processing that movement system, and that interplay between Mulligan and dry needling, it just opens up a lot of opportunities. What's happening between the two groups at this point?
Well, I think if in my Mulligan courses, when I was still teaching Mulligan courses, and I was doing dry needling at the same time, I said, look, putting those two things together makes perfect sense, and I'm doing that now. So in my needling courses, when we talk about ankle problems and stuff, I'll show them an MWM for lateral ankle sprains, right? And they're all like, oh, you got to be kidding me, right? So now you want to take dry needling and you want to use it for anti-inflammation and to reduce edema. Now you can the manual therapy effects of the MWM become even greater. Add some tape to it, and a person who's limping up on the table can literally walk off the table now, right? And they come back, the swelling is much better, the pain is much better, just opens up a whole nother avenue for which you can now go into more of the functional training and return to sport activity.
Yeah, that ankle one is my favorite one too, because it's, when you think of an ankle sprain, everybody's just locked into the sprained ligament, and then you put this little teeny tiny glide on the malleolus, and all of a sudden it's like, oh wait, I have full range every direction. Like,
I don't understand, honestly, how if you're in sports, you're a trainer, you're a PT, you're a chiro, and you're treating athletes who get a sprained ankle, how you are not doing MWM, needling for anti-inflammation and pain, right? And then throwing a piece of tape on there. I mean, I don't know how you're not doing that.
it's so simple.
It's so simple and so effective. It's really unbelievable. And that was one of the things that Brian always said. He goes, I want to be the person that was shown that our treatment of ankle sprains was wrong, that this is the right way to treat an ankle sprain. So.
Yeah, I mean, that's so hard. And we're talking about the ankle, but you see it at the knee, you see it at the shoulder, you see it at the, all these different fancy techniques and exercises are coming out there, and it's like, cool, but just do that, and it's, it's fixed. What would you say to somebody to encourage them to explore either world?
I think in speaking to, really just for any therapist, but in speaking to the younger people coming out, and I get that asked a lot, so what would you suggest that I do to further my career? And it really ultimately is starting with MWM. I mean, I think manipulation is important, and I think it's a good skill to have. Not everybody, wants to do it, not everybody can do it, not every patient's appropriate for it, right? But I think it's something that is, later on in your career, something that you should go towards. But early on, the MWM gets you understanding joints of the entire body and understands how to move those joints and how to integrate that with the actual movement itself. So I always say, starting with the MWMs is really important. And I also say in the needling courses is, look, we're a profession of manual therapy, right? We don't want to lose our hands-on skills. These young guys and gals coming out are going to go ahead and do some needling, and they're going to see amazing results. And they're going to go, well, I'm going to do that. I'm saying, no. Dry needling is a tool in the physical therapy profession. Right. It is not the profession. So we've got to make sure we maintain our understanding of manual therapy, hands-on, exercise-based stuff. And then we use the dry needling as a tool to just magnify those results, right? And reduce the time it takes to get the results and to help those results stick. So I think, MWM is a wonderful place to get started in your manual therapy career. And I certainly think dry needling is probably that next step that you would take to really help with your clinical results.
Yeah, I agree. And, I was, of course, a student with you back when I started, so I got introduced to both of those right out the gate. And it's amazing the quick results you could get. You're out of school and you feel like you don't understand much, and you learn a few Mulligan techniques, and all of a sudden you're getting some pretty good results right away. And you're like, okay, this isn't that bad. And you kind of build from there.
And I'll ask in the dry needling course, I'll say, how many people have taken a Mulligan course? And do you know how many people raise their hand?
Not a high percentage.
I mean, it's 5-6 people, and it always amazes me. So it's not really taught as well as it should be, maybe in the schools, and people really aren't aware of it as much as they should be. That's for sure. And yet, as I said, we've got 3 or 4 textbooks out. We've got probably 250, 300 research articles. This is not something that hasn't been vetted at a high level.
Yeah. Why do you think Mulligan hasn't become more popular? Because, I do the same thing, and how many, you don't see any hands, and it just blows my mind because it's simple. It's a pain-free technique. So as far as risks and that kind of stuff, you don't really have to worry about much. Why hasn't it? It's just a marketing game. What's the?
Yeah, I think that's probably what it is. I just don't think we've done a good enough job of getting the awareness out there, particularly with the newer generation. I mean, the people that have been around for a while know who Mulligan is and kind of get an idea of that. But the younger generation really just hasn't had the exposure that they need, and hopefully we can change that.
Yeah. I think it's working in an outpatient world, I just can't imagine not having that as one of the tools. And I would say the same for dry needling, right? It's going to change your practice and pretty quickly.
Yeah.
So if we're going to wrap this up and kind of summarize the talk, this idea between combining that neurologic approach, how do you think it ties? I mean, what's the summary of how it ties together?
Yeah, Mulligan by its very nature is a neurological approach, right? It's an additive to movement, and you get that huge rush of neurology just by moving a joint and moving a muscle as it goes through. So that's the first phase of it, right? Is it's a neurological approach. And in IDN, I mean, that's what we do. We do neurological dry needling, and we really look at the peripheral and the central relationships between those two. So if you can go in with a simple needle, create a lesion, change the neurology of something, change the neurogenic inflammation, improve blood flow. Because as we say in our courses, one of the main reasons somebody has musculoskeletal pain is a loss of blood flow. Dry needling does an amazing job of increasing blood flow. So if you can actually get in, increase the blood flow to an area, actually reposition a joint to allow them to move without pain, and then exercise them, the combination of those 2 or 3 things, that's the value and the power of putting together an MWM with an IDN or a neurological model.
Yeah, I love that. There's a slide in the course in the last lecture that kind of ties that local, segmental, systemic effects, and talking about the chemical and the inflammatory components. And it's one bullet, and then when you read it, you're like, man, if you could just do that, you're going to be successful just such a high percentage of the time. So that's cool. Anything else you want to?
No, I think we're good.
That was fun. All right.
Yeah.
Cool. Thanks.